It's top of the hour. Good afternoon, everyone. We have a very special guest today, and our topic is telesurgery, echoing remote surgery to distant location. My name is Ariel Santos. I'm the TexLa TRC principal investigator, and with me today are Max. Max is our IT. Laura Rowald, our new project echo coordinator. We have Mandy Moore, and our representative from the student telemedicine student interest group, Ferris Zaitoni. Ferris?
Hello, everyone. So this educational activity is a project of TexLa Telehealth Resource Center, a federally funded program with F. Marie Hall Rural and Community Health at TTU-HSC, as well as Well Ahead, Louisiana, with generous support from Health Resources and Services Administration, or HRSA. We're also a proud supporter of Telehealth Awareness Week, which is coming up on September 18th through the 24th. So if you look at this slide here, these are going to be some helpful tips for our webinar. Please make sure that all microphones are muted, and also kindly type in your name and your email in the chat box, as well as any questions or comments. Make sure you fill the session evaluation as well to obtain those CME credits. Dr. Santos will now introduce our distinguished speaker.
Thank you very much, Ferris. Our speaker today is one of my mentor and idol, Dr. John Griswold. Dr. John Griswold is a professor and chair emeritus of surgery here at TTU-HSC. He's born and raised in Casper, Wyoming, then went to Notre Dame, go Irish, for undergrad, then to Creighton University for medical school, and trained here actually at Texas Tech. And he went to University of Washington in Seattle for trauma, burn, and critical care, then eventually become the chair of the Department of Surgery here at Texas Tech for 2 decades. He's currently the medical director for Timothy Harner Burn Center, medical director of Nutrition Support Services and Enterostomal Therapy, wearing multiple hats, including medical director of Borden County EMS and executive director of Clinical Research Institute. He is also TexLa TRC's first telemedicine Lifetime Achievement awardee for his pioneering work on telemedicine. Ladies and gentlemen, without further ado, Dr. Griswold.
Dr. Santos, thank you for that very kind introduction. And it's an honor for me to be with all of you. As Dr. Santos mentioned, I've had a lot of interest in telemedicine, mostly related to our burn center. And we actually started a telemedicine clinic connecting with the School of Medicine down in El Paso in the 1990s. So we've had a continuously running telemedicine clinic with them for a long period of time, because we cover such a large area and it's so difficult for our patients to follow up with us. So I've been very interested in telemedicine, and it's that interest that I kind of bring today with this talk that I'm about to give. Now, I do have a couple of disclosures. I'm on the speakers list for Medline Medical. It's a large DME medical supply company, and they do a lot of special dressings for burn wounds. And I'm also on the advisory board for Exerco, which does a lot of OR equipment or makes OR equipment for burn surgery procedures, but neither one of those connections will impact this presentation today. My job, I think, is to talk about doing remote surgery. That's the true definition of telesurgery. And what that really means is that the surgeon is in one place and the patient is in another location, a distant location, and the surgery is done by that surgeon, just not in the same room, not in the same city as the patient. And so we're going to talk about how that works and how that evolved. And if you look here, this little statement that I have on the slide, advances in telecommunication along with advances in minimally invasive approaches for surgical procedures and the development of teleoperated robotic surgical systems has allowed the consideration for surgeons to deliver expert care remotely to locations difficult to access. And I've highlighted a lot of things in there because I feel it's important to walk through or go through some of the advances that have happened, some in the distant past, some in the very recent past, that got us to the point where we can now very easily consider doing remote surgery to difficult areas where the surgeon does not have to be present exactly physically present where the patient is. Now, let me just start with this video. And what you're seeing here, I'm sorry, the writing is a little bit blurred, but what's happening here, this is on the top video, these are surgeons that are at McMaster University in Ontario, and they are doing a laparoscopic Nissen fundoplication. And actually, the bottom picture is the patient who is in North Bay. That's about 400 kilometers or 250 miles away from where the surgeon is actually operating on the patient. And so this is an example of what can happen when you create a remote telesurgery opportunity. The surgeon 250 miles away operating on the patient. And this particular procedure took about an hour and a half, and there were no complications, and the patient did just fine. And this was in 2003. Can I just go forward or no? Gotta play the whole thing. Okay.
Sure.
All right. So this is just about over. That's not good. Okay. There are a couple of terms that I thought we should talk about as we get into this. And the first one is telesurgical procedures. We've already kind of defined that. That's where the surgeon and the patient are not in the same physical location. The surgeon is some distance away from the patient. Now, there are a couple of other terms that seem to be assigned specifically to surgery, although they probably transcend both surgery and medicine, primary care and specialty care. But telementoring with telestrations, mentoring happens a lot as new procedures come about. And so experts in those new procedures will help mentor other surgeons who are not experienced or have not been educated in a particular procedure. And so the mentor can be in a remote location, but still connect up with the surgeon learning the procedure. That surgeon is actually operating in the same room on the patient, but the mentor is the one that's remote. And you can use telestrations, ways to make examples and help the surgeon understand exactly how to do the procedure. Teleproctoring is also very important because as we surgeons learn new procedures, we actually have to be proctored by experts. And that is how we get credentialed at our various hospitals to say that we have gone through all the appropriate processes to be able to do these procedures. So again, the surgeon is in the same room with the patient doing the procedure. The expert is remote and proctoring them while they're doing the procedure. But that surgeon, that expert surgeon, also is connected to the procedure so that they can do some of the procedure if the surgeon in the location where the patient is struggles a little bit. So teleproctoring is in a way kind of close to telesurgery. It's just that the expert surgeon isn't doing the whole procedure and may not have to do any of the procedure if the surgeon who's doing the procedure is doing well. And then telepresence is important because it's the feeling of being at the location. And I think with advances in telecommunication, especially robotics, we've really accomplished that. And so I may make a couple of comments about telepresence as we go through this. But the good news is that currently the advances really let the surgeon feel like they're right there with the patient, even though they're at a remote location. All right, so let me just go through what we're going to talk about here. First of all, I want to go through some of the historic events that really provide the foundation for telemedicine in general. And then we're going to describe the evolution of minimally invasive surgery. It may not be immediately intuitive that things had to happen to get us to be able to do remote surgery, but there are two critical pieces of advances in surgery that had to be in place before we could consider remote surgical telesurgery opportunities. The first is the minimally invasive surgery. So I want to talk a little bit about its history and how minimally invasive surgery in and of itself is a radical change from standard traditional surgery. And then we're going to talk about how that minimally invasive surgery evolved into robotic surgery. And then we're going to talk about examples of telesurgery. One I've already shown you from McMaster to North Bay in Canada. And then we're going to talk and finish up with the barriers that lie between us now and the future of telesurgery. All right, so really, to communicate about medical issues or health issues, this goes back very, very far in our past, in our history. The ancient Greeks actually used lights to communicate to different ships and different islands to talk about medicine. This is smoke signals. The American Indians used smoke signals to talk about, communicate health and health risks and medicine to various parts of their tribes. I don't know if anyone's familiar with smoke signals, but this particular, translation of this particular smoke signal is take 2 aspirins and call me in the morning. Yeah. Well, maybe not, just a kind of a little joke there. Okay, so setting the stage for telemedicine and even more specific telesurgery. First, telegraphic transmissions of EKGs happened in 1906. So some type of communication electronically about health and health needs started back at the start of the 20th century. 1928, the Australians actually were experimenting with teleconsultation in some of their remote areas with Morse code and even voice radio. The first X-rays were sent via fax in 1950. And in 1962, Dr. Michael DeBakey, who was an entrepreneur and a trend changer throughout surgery and medicine, did the first surgery teleconference. And he used an intercontinental communication satellite called Early Bird. And while he was doing an aortic valve replacement in Houston, he was transmitting that procedure to medical staff in Geneva, Switzerland, and they were able to ask him questions as the procedure was ongoing. Now, at the same time, there was another push or impetus into looking into telemedicine and especially telesurgery. And that had to do with the wartime issues that we were dealing with. In World War I, actually up to 90% of the physicians helping tend to the injured soldiers died during battles when they were at the front lines. So it was a very dangerous act or activity if the physician was in the front lines trying to administer first aid or care to these injured soldiers. In World War II, with the improvement of air and ground evacuation and the MASH units, the mobile army surgical hospitals, mortality decreased, but it was still unacceptably high. And so at the end of World War II, the US government really wanted to focus on ways to still have the surgeons available to the injured soldiers, but to remove them or make an environment that was more safe for them. And in 1958, NASA, the National Aeronautics and Space Administration, was developed. And NASA's first effort was to combine with the Department of Defense to start looking into technologies that would help allow the surgeon to not be in the front lines, yet still participate and administer care. So these foundations, both in the military and outside the military, are what really jump-started our opportunities to do telemedicine and telesurgery. In 1965, University of Miami was experimenting with transmitting EKGs via radio channels. In 1972, Kaiser Foundation partnered up with Lockheed Space Company, and they were using remote monitoring of patients or individuals on the Papago Indian Reservation to help provide better healthcare at a remote site. And what really gets us into the modern history of developing telemedicine, telesurgery, and especially remote surgery was the advances in electronic vision connection. This really jump-started all of the process and progress we've made with the electronic portions of technically being able to have remote surgery. And this vision communication improvement was the coaxial cables that were first used in radiology and then in surgery that really set the stage for minimally invasive surgery. And so what do we mean by that? Well, this is an example of endoscopy. And before, endoscopy was done just with a monocular viewing port here. You can see on the left, And this physician in China is actually endoscoping someone, just having to look through the port, and having to look through the port and manage the endoscope was really pretty complex and required a lot of experience and skill. And then on the right, this is the new modern endoscope. So the endoscope is actually connected to video cables, and now up here on the monitor. So it improves the vision and improves the dexterity and makes the endoscopy more straightforward. And it was this connection of the endoscope to a video monitor that really made it possible to move on to minimally invasive surgery. Minimally invasive surgery became a possibility once this high definition camera was successfully connected to an endoscope, and that allowed us to have access to regions of the human body and perform surgical procedures through very tiny incisions, because we could put a scope into a body cavity and be able to visualize what we needed to take care of. And then instruments were developed, and we'll talk about those in a second, that allowed us to do minimally invasive procedures. Also important in this whole process, the Society of American Gastrointestinal and Endoscopic Surgeons was created in 1982, and that eventually became the body that helped promote and train surgeons to learn this radical change in how we take care of patients. And then the first laparoscopic cholecystectomy was done by Dr. Moret in Lyon, France. Actually, laparoscopic appendectomies had been done probably about 5 to 7 years prior to this time. So why was minimally invasive surgery such an important first step? Well, it really radically changed the way traditional surgery is done, because with traditional surgery, the surgeon is standing at the OR table with the patient in front of them, making a large incision and opening up body cavities to find the pathology that they recognize through physical exam, and either manipulating it or resecting it or improving it with their hands. So this is really a hands-on, what surgery up until this point was a hands-on process. The reason minimally invasive surgery was a huge advance is that the first thing is we're doing this through very tiny incisions, some of them 0.5 centimeter to 1 centimeter long. And so obviously your hand can't get in there. So we had to rethink the way surgery is done. This forced the surgeon to adjust to 2 dimensions. So we now did not have 3 dimensions, and so depth was lost. That was a really critical step surgeons had to get over. And actually, in the start of laparoscopy, there were a lot of complications that developed because surgeons were having a big difficult time realizing there might be a structure behind what I'm cutting, but they couldn't gauge the distance and damage something behind what they were actually trying to operate on. Dexterity had to change because we were using our hands and with some instruments to assist us, but now we're using these rigid sticks with little scissor handles that were 18 to 24 inches long and really had minimal motion to them. So our dexterity was lost significantly. And then the surgeon ergonomics had to change. And so let me just show you a couple of pictures. This is a picture of an endoscopic scope, and you can see this camera up over here to the left, and then this is actually the monocular attachment to it, and the camera lens is down here at the tip. But these are the instruments, rigid, they didn't move, and so the hand is back here, and you completely lose tactile sense and dexterity because of this rigid rod that's placed into these little incisions to do the surgery. Allowing us, that was allowed because we had the camera in its location. And this is the room doing laparoscopic or minimally invasive surgery. So over here on the right is the surgeon, and all these people had to hold these rigid sticks that are using retractors holding parts of the anatomy out of the way so that the surgeon could get to things. But look, here, the patient is down here on the table, and the surgeon isn't even looking at the patient. He's looking up here. And sometimes it would be off to the side. So you're standing, looking off to a different direction. Your hands are going in a different direction. And it was a giant change for surgeons to be able to accomplish laparoscopic surgery and do it in a facile, efficient, and safe way. So it took a lot of change for surgeons to do this, but it obviously has caught on and is a major part of how we do surgery these days. Now, the advent of robotic surgery was built on this platform of minimally invasive surgery. But it did a couple of things that were very needed. The first thing is it dramatically improved dexterity. And I'm going to show you the instruments and the hand handles that are used in the robot. And it returned the flexibility and the dexterity of our hands and improved touch, the haptics. And so by using the robot hand pieces, you can actually get a sense of the tissue and feel you have a tactile sense that was lost in laparoscopic surgery. The 3 dimensions return. So now the video opportunities in the robot gives us that 3rd dimension, gives us depth perception, and dramatically improves the dissection capability. Also, it took away tremor. The fine point control of the instruments now is just amazing. I'm going to show you a video in a sec how impressive this is. And then finally, the surgeon ergonomics change. So let me just go through a couple of photos. These are the hand pieces, and they rotate in any direction. And so that surgeon's hand is able to move around, and it really feels, and it's as comfortable as if you were doing traditional surgery with your hands in the body cavity. So the dexterity, the tactile sense, that haptic sense of touch is dramatically improved with the robot. And this is a robot room. Now the surgeon is in the room. Where's my cursor? This is him sitting at the console, but a lot more relaxed than having to stand and turn your head away from the patient and those kinds of things. I remember learning how to do laparoscopic surgery, and man, after every case, I had a giant headache and my neck hurt, and it took an awful lot of perseverance, I guess, to really feel and grasp laparoscopy. But sitting at a console, the surgeon's looking through this viewing area that actually even has padding to rest their head on it. So it's a much more relaxed, more comfortable way, and that needs to be that way, because surgery is difficult enough, and to have to struggle with your body ergonomics, it just doesn't lend for a comfortable way of doing surgery. The patient is off here to the surgeon's right, and then there are technicians that are needed to help change instruments in and out. This whole complex here, hopefully you can see my cursor here, is the part of the robot, and they have arms that are extended out with the laparoscopic equipment, like I showed you in the body. But now the robot controls that, all controlled by the surgeon in these hand pieces here at the console. And this is an example. So even the instruments have changed. All of the instruments now have flexibility at their tips so that they move as our hands move. And so really the instruments truly become an extension of our hands, as opposed to our hands having to adjust to those rigid stick-like instruments that the laparoscopy. So dramatic improvement in the range of motion and dexterity. And this is an interesting video. Now, I actually had mentors that told me that as surgery residents, we needed to work on our skills so much so that we could literally peel the skin off a grape without damaging the pulp. Well, I can promise you my technical skills never got to be that good. But this is a real video, and the surgeon is running the console, running the robot. This is the robot actually incising the skin off the scrape. And you can see there, there's no tremor at all. The motion is so well controlled and so finite. And it just, everything is so precise. Just an amazing capability with both the instruments and the control by the robot. And if you notice here, they're just removing this, the peel or the skin off the scrape. You can imagine how difficult that would be without having the robot control. And if you look, the pulp or the meat of the grape has not been damaged. You would think that at least a little bit of that scissor arm would cut the pulp, but it is so well controlled that it's just cutting through the skin. That skin is about 1 cell layer thick. So that's how incredible. And you can also see how the magnification is increased. So although we had improved magnification with the laparoscope, now we have dramatic improvement in the robot camera as well. Is it still going? Yeah, maybe we can just, oh, thanks. Okay, another video here. Now, on the left is a laparoscopic view of a Nissen fundoplication. So Nissen fundoplication, for those of you who aren't surgeons, that's how we treat severe reflux or heartburn, if you will, for acid refluxing up into the esophagus. And there's a way we can wrap part of the stomach around the esophagus and make it pinch off better and keep the acid in the stomach. And that's what the procedure is here. On the left is a laparoscopic Nissen fundoplication. On the right is the robotic Nissen fundoplication. And first of all, just look at the 3D. Hopefully you can recognize that on the right. Now you have depth perception because you can see how things look farther away and closer to you. And it just makes things much more safe and the dissection much easier to do. The visualization is better. And look at how quickly this surgeon is able to sew, that what they're doing is sewing the opening in the diaphragm tighter. And you look on the left, the poor surgeon here is still struggling to get the needle, the first pass of the needle through the tissue, and the surgeon on the right is already tying the knot. So much farther ahead on the right side. So it's more efficient. It's easier for the surgeon to do and much safer, again, because that depth perception. But you can see the control there. I mean, it's just amazing. Yeah, so the surgeon on the right's done with that diaphragm closure, and you can see the surgeon doing the laparoscope is still struggling some. Okay, I think we can go to the next. Maybe I can do that. Oh, perfect. All right. So hopefully I've convinced you that we had to go from traditional surgery to the minimally invasive surgery through small incisions because that's the way the robotic process is done. But we had to probably struggle a little bit getting through what now probably seems like archaic equipment to get to the significant advances of the robot. So we really are combining the best of both worlds: traditional surgery with the comfort and the confidence of the dexterity and the touch, with real-time telepresence on the monitor, and then the incredible skills without tremor and dexterity that the robot allows us. What I want to do now is just go through a little bit of the history of the robot development, because this is important for us to understand where we are today. Actually, the first robot, in other words, the surgeon not actually doing the procedure, but in the same room controlling the instruments, is the Puma 560 robot, which was used for stereotactic neurosurgical biopsies. Obviously, if you're taking a biopsy of the brain, you want to have it as precise as possible, and it was really important to make this advance. So this is really taken over as ways to do deep internal central nervous system biopsies. Probot was the first transurethral resection of the prostate capability. And NASA, in conjunction with Stanford University, they have a whole telemedicine and telerobotic research institute. And they are the ones that developed the dexterity portion, not only of the hand pieces, but of the instruments. ASOP was a voice-controlled camera. So it got us to the point where the surgeon's still doing laparoscopy, but they didn't need all the assistance because they used voice control to have the camera look and move wherever they needed to. So that became somewhat controlled or automatic. In 2000, the FDA approved the first telesurgery robotic system, was called the Da Vinci system, and the company was Intuitive Surgical. In 2001, Zeus robotic surgical system came on the market, and it was the second generation of that ESOP voice activated camera, and it's now a full robotic system. Now, it's important to the history, the recent history of this. Intuitive Surgical actually acquired Computer Motions Inc. that made the Zeus product, and the Zeus product line disappeared. And that's kind of important to understand some of the advances that didn't move as quickly as we thought they were going to because of that takeover by Intuitive Surgical. And as a matter of fact, Da Vinci was the only FDA-approved telesurgery system until 2017, and now there are 2 more companies that are approved. But it was the only telesurgery system out there until about 4 years ago. Some important procedures. Actually, probably the most famous one is this Operation Lindbergh. This was using that Zeus robotic system that was came out in 2001, and the surgeons were actually in New York, and the patient was in Strasbourg, France. So 6,000 kilometers, 4,000 miles away. And important is the delay in the transmission was only 155 milliseconds. And we're going to talk about that in a bit, because that's one of the critical hurdles we still have to get over, the delay in the information coming back to the surgeon to make it feel real time. OR took 54 minutes, and it was a laparoscopic cholecystectomy, and there were no complications. So Operation Lindbergh really put remote surgery on the map, if you will, and made us realize that it's definitely doable. 2002 to 2003, that project in McMaster, the one procedure I showed you at the beginning, they actually were developing a telerobotic service at a small hospital in North Bay, a community hospital that didn't have surgeons. And they did actually 22 robotic procedures on patients up in North Bay using the Zeus system up until it was discontinued after Intuitive Surgical bought out the company that made Zeus. Since then, there have been 20 publications of remote surgical activity and in just about every field: general surgery, urology, orthopedics, cardiovascular, neurosurgery, gynecology. So there's no real limit to the types of procedures that can be done. In addition, the Department of Defense has made miniature robot surgical systems that can be placed on at the front line and actually controlled by surgeons at a remote location. So the safety of physicians has been improved with these robot systems. The other important part about these miniature robot systems, they're very light, easy to carry on a backpack, and easy to assemble. And it's amazing. They're really not very complicated. And that's really important, because you saw in the video about the robotic procedure, that's a massive amount of equipment to have in a room to be able to complete these procedures, and to be able to miniaturize it really has added strength to the remote capabilities of using robot surgery. There's actually a lot of activity with NASA. Of course, NASA was involved with this from the very beginning, but they have a program called Extreme Environment Mission Operations, NEMO, and they've used that and the Undersea Research Center that's off the coast of Florida to prove that you can do telecommunication and remote surgical connectivity, and even have robot systems set up even underwater or far away at sea. So that remote environment is now been proven to be accessible for remote surgery. And they've even done weightless robotic capabilities. And so, at least to some degree, even in space, remote robotic surgery is doable with the physician here on Earth. So let's talk about the barriers. Haptics, that's the tactile sense, or the computer term for tactile sense, that's been fixed. So we've been able to fix the haptics and improve the dexterity of the surgeon. Flexibility of the instruments, that's been fixed. The ergonomics for the surgeon has been fixed. Visibility has now been fixed because of the 3D ability to see with even 10 times magnification of the laparoscope. so improved depth perception and improved magnification and no tremor. So the biggest issue as far as the technical approach or technical aspect of robotic remote surgery is the latency period. I mentioned in the Operation Lindbergh, it was only 155 milliseconds. If it goes past 200 milliseconds, the feed is delayed enough that the surgeon's movement is happens before the surgeon sees it. And that really sets the stage for potentially in complex surgery errors, and some of them serious errors. So the latency period is one area that's a problem. Now, as I mentioned, the latency mark that we're trying to shoot for is less than 200 milliseconds. If it's higher than that, then there is risk to be had. Now, the Operation Lindbergh was able to do it, but look at this. They required 40 technicians focused on the data feed alone. They did this actually through a coaxial cable transatlantic, and they had to reserve time. That one procedure cost an awful lot of financial input and a lot of people to make it work. So it is doable, but we still got a lot of work to do to make this a commonplace opportunity. The 5G network has been a great boon as far as thinking more about telemedicine or telesurgery and remote access, but still, the 5G network was considered a short-range service. It is about 100 times better than 4G, but if the distance gets too far, its latency period increases. And so 5G, although better for close in, for instance, the surgery that was done in Canada there at North Bay, it works, but much longer distances, which is really what we're hoping to achieve, right? It's the latency period is going to be a problem. And so advances in the speed and the bandwidth has to occur before we can really say that telesurgery in remote locations has arrived and is safe to do. There are other barriers that we have to work on, but these are not really technical. It's more legal and administrative, regulatory approval. Gosh, if we're doing surgery in one country and patients in another country, there's a whole host of medical legal issues, licensing, device approval, and what happens and actually China has 2 or 3 of their own robot systems. Well, what if we have to use their robot system, but we don't know, but it's different than our robot system? So similarity or consistency in these robot systems needs to occur to some degree, at least, to make it safe. We have to deal with the patient side, standardizing how we get consents, making sure that the patient understands. Many times the patient probably will never, or could be a situation where they never meet the surgeon ever. And so we have to get across that. And especially for those of us who are surgeons who, feel strongly about making sure our patient understands what we're going to do and what the risks are. This could be a big hurdle for us to get over, both on the surgeon and the patient side. I mentioned space. If the distance gets longer than 380,000 kilometers, then it actually, the return of the data, the visual data, the tele connection is considered semi-real time. So it is going to be a delay. And so in distant space, probably telesurgery as we think of it, real-time telesurgery is not going to be doable. And so we still have to have advances in the robot to be able to be automated. Now that, I don't know, might worry some people that you've got this robot operating on you to take out your appendix with no surgeon even around. But if we're going to take it that distance or look at those kinds of distances, it will have to be to some degree an automated robot that does the surgery on their own without any connection to the surgeon. Cyber attacks. There have actually been a couple of practice cyber attacks, and that can be devastating to the procedures. So if a cyber attack happened while a surgery was going on, it would be incredibly impactful in a bad way to the outcome for the patient. It can disrupt haptics, prolongs the latency, complete loss of robot control. So safety mechanisms have to be put in place to protect the electronic or the communication infrastructure that is being used for robotic remote surgery. Cost is a big part of this. Da Vinci robot right now costs about $2 million. Those robot systems that the military has developed are less expensive, but still expensive. And so it's going to need to be more affordable. It's just going to have to be, because we want the robot to be in these remote locations that probably financially don't have the capabilities of setting up something complex like a $2 million robot, Da Vinci robot system. And there are a myriad of other ethical and legal and liability things that will have to be considered before it becomes commonplace. And then I'm going to finish with just one aspect that is concerning. Maybe this is me as in the senior part of my career, but if you think about what's happened with minimally invasive surgery and robotic surgery, we are training surgeons to be able to do surgery in the non-traditional way. And so they are becoming dependent on the visibility that the cameras provide them, the dexterity and capability that the robot provides. And what happens if in the middle of that operation, whether the surgeon is in the same room or not in the same room, and the patient needs to be opened up, so to speak, to do damage control for a complication. And I worry that as we put more and more effort into these really unique advances, we are going to lose some surgical capabilities that still need to be there, at least as a backup. It's in a way we're almost dehumanizing this whole process, and it's becoming more of a electronic gadget gizmo, and not realizing that it's being used on or working on a human body. So I think that needs to be worked into the training of surgeons. Already, it's a struggle for the surgeons, the surgery residents that we work with, realizing that they have better skills on the laparoscopic side, maybe, than on the traditional open surgery side. So at least it's something to think about, and food for thought as this progresses. I appreciate you all giving me the opportunity to talk about this progression to getting us to the opportunity of telesurgery in a remote location. I think it's definitely going to be the sign of the times, but we still have some work to do. Thank you very much.
Thank you very much, Dr. Griswold. That is an excellent presentation.
Yes, thank you, Dr. Griswold. Everybody, don't forget to fill out your session evaluation survey to obtain your CMEs. We're now going to open up the floor for questions.
I think we had one question from chat from Adrian Billings.
Oh, Dr. Griswold, there's a question from Adrian Billings. It says, is the latency period more of a concern when connecting to rural areas of Texas owing to a less robust broadband?
Yeah, absolutely. So it's a problem to connect to areas where the networkings tend to maybe overlap a little bit depending upon the company that you're using, but the strength is not good. Like, so instance, you could get good audio, but not video. So that has got to be worked out. And unfortunately, I think it might be the thought that, well, let's just use satellite feeds. But satellite feed latency is actually worse than 5G right now. So the satellites currently are not the answer. There is, and I may have not put it on one of the slides, but there's a company in Canada that is actually submitted to both the FDA in US and the similar body in Canada to put up about 74 low orbit satellites that could give worldwide connectivity and be as quick and capable as 5G networks. So now that's just in the philosophic phase. And I do think eventually to fix issues in rural areas and lack of overlap of network power, satellites probably will be the one of the ways we get to that point. But right now, satellites are not any better than 5G.
Thank you for that answer. And I guess just a follow-up question related to that is I was really interested. I didn't know the term of telementoring with telestrations. And my perspective is as a recovering rural physician, having practiced the past 16 years in the Big Bend. And the one time that I had to take a hypotensive patient back to the OR with a ruptured ectopic because she was too unstable to transfer, and we did not have an OB-GYN at the time. I had done an OB-GYN fellowship and was comfortable doing C-sections, including laparoscopic tubal ligations, but I had never done as a primary surgeon a laparoscopic salpingectomy on a patient for an ectopic pregnancy. So this poor patient had no other option than me because we could not transfer her out of Alpine. And so I took her back and did a laparotomy and did a salpingectomy, and the patient did just fine. But I was involved in 2014 with the WHO and the US delegation in a proposal that was making its way through WHO and training I forget if it was 7 or 11 life-saving emergency surgeries to generalist physicians. And this was primarily meant for developing countries. And examples of these were ectopics, DNCs, C-sections, incarcerated hernias, and some others. But I'm really interested, in that scenario where I was in the OR performing a surgery that I wasn't as comfortable as I would have liked to have been. It would have been great to have a camera in the OR, a surgeon like you in Lubbock or Midland or Odessa or somewhere that could just really hold my hand virtually. And so I'd love any thoughts of models of that. I'd love to talk about this more with you if possible. And as you know, the rural general surgeon is incredibly hard to recruit and retain. And the specialty that is most present in rural areas are family physicians, not all of whom have robust surgical training, but I think there's certainly some interest in that from rural family physicians and getting that training to better serve their rural patient populations. Thank you.
Well, this is a very important topic related to this. And I would suspect that even a surgeon who is promoting remote surgery, being the active surgeon, would love to have a physician in that location where the patient is to be able to monitor, help, participate, whatever. So I suspect that most, at least in the near future, however long that is, most remote surgery is going to have to be some kind of a partnership between the surgeon remotely and at least a physician who they've already communicated with, and they are in sync, with the procedure and technique. So I think this is going to be a vital part of remote surgery moving forward, because I know I'd be scared to death if I was just, they would just walked in and all they had were scrub techs putting the instruments in, and no physician around to help deal with something if something bad happens. So it's going to be a critical piece to it. And I think that's a good thing, because the rural physicians need that training if they don't have the connection.
And actually, let me just add, Dr. Griswold, when I was actually in Canada, I was in level 1 trauma center there, and there are some critically injured patients that required chest tube, and some of the family physicians who are the emergency physician in rural areas, they're not very familiar in doing some procedure like chest tube central line placement. So I walked them through the procedure while I was there. So there's a telepresence or telementoring. And actually recently, Dr. Vaughn had a question, but Dr. Vaughn is being mentored on doing a robotic surgery, an acute care surgery patient. And his mentor, unfortunately got sick. And so was virtually mentoring him through the case.
Interesting.
Yes, sir. And you probably met Dr. Brian Davis. Dr. Brian Davis is an expert in common bile duct exploration. And he already volunteered to us that, if we have a case, he doesn't need to fly going to, from El Paso to Lubbock, but he could proctor, our surgeon to do a common bile duct exploration robotically or laparoscopically through a virtual connection. Anyway, Dr. Vaughn had a question, Dr. Griswold. Thank you, Dr. Billings, for the question, by the way. Do you see a day in the future where a significant percentage of surgeons will operate from home on robotic consoles? And do you see a role for specialist remote robotic consultation where, say, on a HPB surgeon could assist with injury to the common bile duct during lap chole?
Well, as to the first question, I mean, I really like my slippers, and so I probably could get into a situation of dreaming about that. But I think maybe the onus may be on us, but we should make it as professional and reliable as the patient needs. So I doubt we'll be at our home, but it still will be nice not to have to travel. And to be able to sit at the console and feel confident that you're able to take care of the patient without disrupting the patient or your environment to take care of them. So I think there's a lot of social benefits to it if we can work through all these other struggles. But as far as HPB surgery and I think right now telementoring and teleproctoring could happen. And that's exciting because I think it will allow surgeons and surgical trainees, residents, to be able to experience complex surgeries. One, because maybe they don't have the right volume, or maybe the expertise isn't in their department. So I think that aspect really is fertile ground even now, and hopefully we can all participate in that and work towards developing those opportunities so that we stay connected within our region for sure.
And I think there's an opportunity, Dr. Griswold, wherein, some of the operations are recorded that, there is a real-time mentoring at the same time. You could go into the case and these are the things that you could done better.
That's right. Yeah. Debriefing.
There is another question, sir, from Larry Llewellyn. How is 3D achieved? 2 cameras. Is there any thought on having the surgeon instruct the robot to automatically suture a defined suture line?
Well, your question about 3D achievement, it's not 2 cameras because it's worked into the single camera. So, and that is the extent of my knowledge. I can barely spell electricity, so I just wanted to tell you about that. But you can see from those videos, it really is very functional, truly functional 3D. And we don't have to wear special glasses or anything like you do at the movie theater. But as far as the second questions, they're already through the Department of Defense and Stanford, they've actually made an automated robot, and I'm blanking on the name of it, that actually has been tested side by side by experienced surgeons as far as making an incision and closing the incision, and the robot wins every single time. So for those kinds of technical aspects, I'm sure that is exactly how it's going to evolve because it's just going to be better for the patient. I think the critical pieces are, the times when we really have to be able to make changes at a moment's notice, depending upon the anatomy or maybe finding something that wasn't expected. That probably will never be able to be built in or be very difficult to have a artificial intelligence environment where the robot can make those changes. So I think our participation as human surgeons in this process is protected and probably will be needed for a long period of time, thank goodness. But I think there's going to be a lot of automation that is going to be very, very beneficial and just an improvement to what we do now.
Well, that would be the day wherein we could work at home, sir.
Well, maybe. I can wear my slippers.
We already wear the pajamas, so.
That's right.
So is there any other question from the crowd? And I think, Dr. Griswold, telesurgery is evolving, technology is getting better as well. And, there's telementoring, teleproctoring. However, we're using also telemedicine to evaluate patients pre-op, so there's an intraoperative, like Dr. Griswold mentioned, but preoperatively, because sometimes we will see the patient, right, sir? And we will just order, hey, I need a CAT scan or this imaging. Those are the things that we probably could do virtually. So to avoid the travel of our patient coming from El Paso to here or from Eastern New Mexico to here to, save some time, especially right now, the price of gases, is very expensive.
Well, even in my world, in the burn center, probably not amenable to telesurgery. I don't think we'll ever use the robot to do a skin graft, but for us, what we struggle, our burn center covers a catchment area of 220,000 square miles. And we've always known that our follow-up in clinic is not equivalent to the number of patients we're seeing on the inpatient burn center side. And actually, my partner, Dr. Baradia, and several medical students did a project that showed that the farther away the patients get in that huge area, the less likely they're going to come back. And really, it probably makes sense. The more seriously injured patients are going to come back because they need our help to improve and continue their recovery. The pediatric patients, burn patients that we see, because the parents are going to make them come. But the younger adult with not too serious of an injury, they just never show up. And that for us, that's as high as 45% of our patients annually.
Yep.
So it's a huge patient that really, and I'm sure they'd be very happy for us to create a telemedicine opportunity so that they don't have to deal with that. And Mandy, you do that all the time.
That's where I do it. And I think it's easy because we do service so many people from Eastern New Mexico. If a post-op patient calls with a complication, they're 2 or 3 hours away and they're trying to decide, should I go to the ER? Should I come see my surgeon? Just jump on telemedicine real quick and you can make a decision. And that's been so beneficial to our department.
Yeah, absolutely.
And most of our cases that are uncomplicated appendectomy and uncomplicated cholecystectomy are being followed up by Mandy. Mandy is actually one of our super user, in telemedicine, and there's a lot of cost saving, not just with the patient but with the physician as well. Because I think we could see them, in 5 minutes, compared to 1 hour being, waiting in our, registration, then rooming in, then getting discharged. All right. Do we have any other question from the crowd? This is excellent talk, Dr. Griswold.
So good.
I really enjoyed it. All right. Well, don't forget to do your session evaluation, and we would like to present Dr. Griswold this challenge coin. Our token of appreciation. For this wonderful talk. And Dr. Griswold is a friend of telemedicine and a friend of TexLa TRC. And I just like to remind everyone that next month, Dr. Emily Hayden, the Director of Telemedicine at Massachusetts General Hospital, Department of Medicine, Emergency Medicine, will be giving a talk in virtual care in the emergency room, current and future trends. And apparently at MGH, sir, they already having virtual observation room,
Really?
wherein they are at home, but they're being managed by MGH remotely. So again, thank you everyone for your presence and have a good afternoon.